Hello again. Full disclosure, this is my second plenary talk. All right, and so this afternoon I'll be talking about our 30 by 30 health systems initiative. I started with CCIH about 5 years ago, and so it has been a pleasure to see how this initiative has grown. We are also about 5 years into the initiative, so I'm happy to share that with you. I'm going to see if the clicker works this time, but I'm afraid it's not working, so I will do next slide. All right. So 30 by 30, if you haven't heard of it, is the goal, overarching goal, is to strengthen 30 health systems by 2030 through faith-based organizations. And so here our objectives are really focused around visibility, building an evidence base for health system strengthening, and really increasing the capacity of faith-based organizations to do the good work that they are already doing. Next slide. So here's our 10-year timeline. Really happy to share we finished up our midterm evaluation last year, and so I'll be sharing some of those results with you today. We are in 2025 now, and we have 2 more years where we're accepting commitments. So if today is the first time you're hearing of 30 by 30, or you've heard of it before and considered making a commitment, next year we're opening up our commitments again. So please do think about it as I go through the presentation. If you have questions about what it means to make a commitment, talk to me after this, but we are happy to see more FBOs get involved. Next slide. I love this slide. This is my favorite slide of the presentation because here are 35 FBOs who are active commitment makers. And this is just the 35 active commitment makers. Over the first 5 years, we've had 46 commitments to health system strengthening. And so I was really happy to share about 30 by 30 at the American Health Association meeting this fall and showed this screen again. And so we are trying our best to really increase the visibility of the FBOs that are involved with this and involved with the global health work in general. Next slide. So how 30 by 30 works is FBOs utilizing the programs that you're already doing and the work that you're already implementing, make a commitment to one or more areas of health system strengthening. So we go by the 6 pillars, WHO pillars of health or health system building blocks, and plus one more, which is community services, because many of you do a lot of community services work that really invests into health system strengthening, and we wanted that to be represented here. You can see even community services is the second most popular commitment next to health workforce. I will say too, out of all of the commitments, about 60% of them are focused on sub-Saharan Africa. So there's a breakdown globally, but most of them are focused on sub-Saharan Africa. Next slide. So I'll be going through some summary indicators, but I should mention how the commitments work is once a FBO makes a commitment to health system strengthening, we talk through a couple of standardized indicators that we have for each of the areas, and then each year there's some annual reporting on those indicators, and we collect them all, we aggregate them, and then share them across the board of this is what FBOs are doing to strengthen those health systems. And so we have broken them down in a socio-ecological model at different levels. So I'll just go through a highlight or two at each level so you get a flavor of what the impact of health system strengthening is. At the individual level, there's a huge, you saw as in the health system strengthening pillars, health workforce is the most popular. So there's been a huge investment in training and capacity building. Over 60,000 people have been trained through FBOs, through 30 by 30, and over 8,000 training programs. And so on the right side is a list of some of the areas, some of the training areas, but the list goes beyond this. Also at the individual level, I'll mention over 6 million people have been reached by health programs through FBOs involved with 30 by 30. Next slide. At an institutional level, we've seen about 11,000 institutions supported by FBOs and supported in different ways, whether that be leadership and governance support, data management support, HR support. There's a lot of different areas where institutions have been supported. Next slide. Community, my favorite level here. We see a couple of important indicators. I really wanted to highlight the church groups involved in health because this is, of course, a faith-based initiative. All of the commitment makers are faith-based organizations, and so it's really cool to see how the church is involved, especially in this session focused on the church as health and change agents, seeing over about 4,500 churches involved with health is a pretty neat thing over the first 5 years of this program, along with about 1,000 community groups as well. Next slide. At the systems level, we see a lot of partnerships have been formed over the first 5 years. And so these are not just FBO to FBO. We see the top area is FBO to government. We know a lot of you work with the government, and we encourage that. Public-private partnerships are the way to go when it comes to health system strengthening, because that is one area we're working with the whole system, and we really want to be working together and working cohesively to build up the entire system. Next slide. So I would be remiss if I didn't share some direct feedback from commitment makers as we were collecting our data from the midterm evaluation. We heard a lot of good things, a lot of things that challenged us, shaped our recommendations, but I just chose a few quotes here to highlight the top two things I think we heard as what people appreciated about the 30 by 30 initiative. The first being the sense of unity. That, you know, it can be isolating working in one place or working in one area, but if you look across how the systems are being strengthened, people get a sense of unity and, okay, we are working on this together. Maybe I'm working on health workforce in Indonesia, but you're working on health workforce in Tanzania, and we are both making an impact, a collective impact. The other area is data management. And the structure of how we collect indicators. We provided a lot of technical support to some FBOs that maybe didn't have as strong of an M&E area to even understand how to set up an indicator, how to manage that, how to track it, and looking at the long term, what do you want to see out of that? Next slide. So if you were here yesterday, you heard Doug talk about our strategy in the 3 areas, and so I wanted to kind of break down what we see as the future of 30 by 30 in those, broken down into those 3 areas. So visibility, that's one of the major parts of 30 by 30 is sharing with the world what FBOs are already doing. And we're working on a couple of things, sharing impact stories, and then also working on a flagship publication. Quality, we're continuing to invest in capacity building, especially for the data part of this initiative. And then fellowship, creating some communication channels between commitment makers, including some forums that are focused on each of those health systems pillars so we can exchange ideas, talk about challenges, and work through those together. So that's 30 by 30. Please do talk to me if you're interested in making a commitment upcoming. I meant to do this at the beginning, but I would like to see a show of hands. If you are a commitment maker in this room, can you raise your hand? Yeah, that's pretty cool. Well, thank you for the investment in this initiative and the good work that you're doing. That's all.
The board of directors started issuing what they called International Health Champion Awards. And many of the individuals in this room are recipients of that award. A few years ago, as we were retooling how we thought about the conference, we changed up the nature of the award, or the board changed it up to create an award not recognizing an individual, but recognizing an institution, because often the success of what they do reflects what the institution or what all of the staff do and their volunteers and all of that, rather than the contribution of any single individual. So we started doing that, and in 2023, we had a an award that recognized what was the theme of that time? I can't remember 2 years ago now. Oh gosh. It was something really great. Only surpassed by this year's really great, which is Change Agents for All. So now I better sit down and turn it over to Priya. Priya John is a board member, but she's also the General Secretary of the Christian Medical Association of India. And Priya is going to come up and talk about this year's award recipient and actually issue the award. So Priya, over to you.
Good evening. It is my privilege, and I'm very grateful to the board of the CCIH for giving me this privilege to present this year's Change Agent Award, which is a very prestigious award. This year we are giving the award to the Christian Medical College, Vellore, the Distance Education Department. Now, this little department, well, it's not little now, but it started off as a little desk. And it started off with the vision of one man in 2007. And that vision was taken forward. And now it runs several diploma programs, both at the international as well at the national level. And it caters to all members of a healthcare team. It's not directed only at doctors or nurses, but to the lay person who might be the only person in a community giving care. And that person is also considered important and as a change agent. The vision of this one man, Dr. Vinod Shah, which was started in 2007, was taken forward by Dr. Jakin Vellore, who's right now currently the head of the Distance Education Department in Vellore, and she's also the Associate Director for Missions. And she is the one who has just, fulfilled this dream in so many different ways. And by God's grace, this department has really grown and changed so many lives across many countries. In our own country, there are important partnerships it makes with the government also. So it's recognized as a very important training partner for especially states in our country where training and expertise and skills are lacking. And that is in the northern part of our country. And CMC Vellore Distance Education Department is consulted, and they take the lead for training all the healthcare workers under the government. And that is a very special privilege and a recognition. So as the CCIH board, on behalf of our board members who are here, I take this privilege, Doug, to give this award to the CMC Vellore Distance Education Department. And we will first hear from Dr. Jakin. She has a small response speech, after which we have a representative from the department, Dr. Sunita Varghese, who will accept the award. So over to Angelica for the recording.
Vellore, India. I'm an Associate Director of CMC Vellore, and my portfolio is Missions, and I'm the head of the Distance Education Unit. The Change Agent Award by CCIH is very, very special on so many counts. And I accept it today on behalf of so many stakeholders who are part of the Community Lay Leaders Health Training Certificate course, which is run by the Distance Education Unit in CMC Vellore since 2011. And interestingly, the tagline is Be a Change Agent. Here goes my list. Good. I accept this award on behalf of my institution and alma mater, CMC Vellore, one of the biggest mission hospitals and teaching institutions, highly regarded in the nation, founded by Dr. Ida Scudder, an American missionary who never wanted to be a doctor, but responded to a need after seeing 3 young women die in childbirth for lack of a woman doctor in a single night. Today, with over 4,000 beds, 3 million outpatients and about 1.5 million inpatients, and another 1 million touched through community outreach, and running more than 200 courses and giving more than 200 crores as charity annually. CMC walks the talk in line with its motto, not to be served, but to serve, for the last 125 years. I accept this award on behalf of my department, the Distance Education Department. Yes, CMC has all these reputations and facilities now, but can everyone access training here? Can we take good training and capacity building to the doorsteps of all levels of healthcare professionals? Distance Education Unit does this with over 20 need-based courses like mental health, geriatrics, rehabilitation medicine, family medicine, lifestyle medicine, etc., through the platform of blended learning. I accept this award on behalf of the CLHTC team. It's a nurse-led program. We have a handful of master trainers who are nurses assisted by doctors who work on a cascade model, training over 100 nurses in our mission hospitals as regional nurse trainers since 2011. I accept this award on behalf of the mission hospitals, over 16 of them who've given their nurses to be trained as regional trainers, and they train the missionaries and pastors. They give their venues, their patients, their support, and their help in every possible way for us to run this program. I accept this award on behalf of the trainees and graduates of the CLHTC program. These are the pastors and missionaries who are trained by this program, 2,200 in number in over 27 states across India, being quietly salt and light and bringing about a quiet health transformation in their communities, empowering village volunteers, schools, and everyone in their community with right knowledge, attitudes, and practices about health, resulting in a multiplier effect. I accept this award, my friends, on behalf of the people and communities in India. Many of them have no access to good health care, and they are benefited by these missionaries and pastors who are trained by CLHTC. Over 15,000 villages, consisting of about 15 million population, are benefited by this program. Long ago, in the rugged plains of Judea, a small boy gave a bundle of his food in the hands of the Son of Man and watched in amazement as it multiplied in his hands and satisfied the multitudes. Only the Lord can bring change in anything, be it human hearts, health beliefs, or the health scenario. Ladies and gentlemen, I believe that this recognition not only inspires all these groups of people that I mentioned, but will, I believe, pave way for more networking and collaboration through CCIH. And it can be a change initiative in many areas of need across the globe. Once again, thank you very much for this award, and God bless.
Those are special moments, and a terrific organization. If you haven't had a chance to visit CMC Vellore, it's life-changing. And we really appreciate and really value the work that happens in that unit. All right, friends, I think we're now getting to the final stretches of the day. We are going to head now to our second major plenary. Remember this morning we talked about change agents in the political landscape. We talked about the U.S., we talked about the European landscape, and we also had the privilege to hear from the voice from PEPFAR right now. We're changing up the conversation now to talk about church as change agent. And so with that, we have a very special plenary planned next, and Yoram Siame from the Churches Health Association of Zambia is going to lead us through that. So Yoram, I'm going to invite you, please, to come on up, and we can go ahead and Mona is giving me instructions of everybody should come up. So we're going to invite Monsignor and Priya to come on up as well and take your seats. And Yoram, come on up, please.
Good afternoon. Is it a good afternoon? Some people look like it's just an afternoon. Welcome to this interesting plenary in which we are going to look at the church as change agents. And this plenary discussion is inspired really by two things. That the church has historically played two roles. It's been the hands and feet of the church to bring about the kingdom of God in the health sector, but it also played a prophetic role to speak truth to power and to challenge health injustice. This session will seek to really delve a little bit into a reflection. When you look at the church's role in providing holistic care, but also speaking truth to the health injustice that is all over the world, can we truly and honestly say today that the church continues to play that role? And we're also going to ask ourselves, if indeed we are, as church, to continue to play this role, what sort of questions should we ask ourselves? What should we do to strengthen this relevant and important role that the church should play? And with me, I have the honor and privilege of being in between two people who have got a wealth of experience and wisdom on the subject matter. I will start by introducing Dr. Priya John, who is from India. Dr. Priya John has served as General Secretary to the Christian Medical Association of India since 2019. So she got in the job and immediately COVID hit. And before that, she worked at CMAI's Community Health Department and Palliative Medicine in New Delhi. She earned her MBSS from the Christian Medical College, Vellore, and completed postgraduate studies in community health and preventive medicine at St. John's National Academy of Health Sciences in Bangalore. She brings extensive experience in faith-based health leadership and community care, and you can see from her qualifications and experience that she was really trained by the church, has worked in the church at different levels, and now she is a leader in her own right in contributing a big chunk of India's health system. Please contribute and welcome with me Dr. Priya John. You can see that there's an expectation in the room. I now introduce Monsignor Robert Vitillo. Monsignor Robert Vitillo is Senior Advisor at the Vatican's Dicastery for promoting integral health development. As you can see, he's a priest. He's a Catholic priest from the Diocese of Paterson, New Jersey. He's a trained social worker with expertise, very unusual expertise in migration, child protection, HIV/AIDS, global health, etc., etc. He has led programs with Catholic charities, Caritas Internationalis, International Catholic Migration Commission, and represented the Holy See at the UN. They used to call you Your Excellency also? He is fluent in 4 languages, and there's a new nugget I learned today. He was one of the people, when the Pope was just elected, who was helping the media very unconsciously to translate Latin. He knows Latin. How many people here know someone who can speak Latin? Now you know. Thank you very much. So welcome me in welcoming Monsignor Vitillo. So because this session is essentially about asking those very important questions, I will go straight in and ask Dr. John Priya, from your experience, how has the church served as a voice for health, and in your opinion, in its task as a voice for health, what has been most impactful?
Thank you very much for the question, and also for the privilege of being part of this plenary and sharing the stage with royalty. I'm privileged to be a part of this plenary only for one reason, because the Christian Medical Association of India, our mission statement says that we work with the church in its ministry of health, healing, and wholeness. So we are all the church, number one. And the second is, when we look at what is the voice of the church in healthcare, in our country, there are different ways to look at that voice. One is when there is a requirement for the faith-based NGOs to support the government in different areas of healthcare. And I think one of the biggest examples was during the COVID-19 pandemic, where they looked to us, the Christian Healthcare Network, to be that support system. And that voice came not only from the Protestant Church, who the CMAI represents, but also from the Catholic Church. And together our voice is loud. And it is not a small voice which can be ignored. And through that Christian Coalition for Health, we made an impact. When it comes to church leaders, the strongest voice they have is when they work with their congregations at the community level. That is when we see the impact. Moving one step higher to the leaders at the diocese level. Now, all the bishops at the diocese level, they always serve on the boards of the hospitals. At that time, their voice has to be the voice of integrity, the voice of non-corruption, the voice of the people and the community the hospital is serving. So and then we have at the synod level, which is little higher, where the moderators come in and you have more colored robes coming in. At that level, we have the National Council of Churches in India who speak up for those who cannot speak. And at that level, we bring in not just health, but also the social determinants of health. And they make a difference when it comes to equity, comes to violence, when it comes to persecution. All that is taken care of at that level. So at all levels, there is an important role for the voice of the church to make a difference, whether it's just for health, but also for wholeness. And that is the privilege that we have as CMA to work with the church.
Thank you very much. The same question, Monsignor Vitillo. How has the church served as a voice for health, and what has been most impactful in your opinion?
Thank you very much. And Dr. John has really mentioned the different levels, and I'd have to say that in my own experience within the Catholic Church, it's the same levels in many ways. There's one small difference with this, but before I go into that, I want to mention, the mission of the church as I see it. And just recently, during the last couple of months, We've celebrated the passion and death of our Lord Jesus Christ, his resurrection, his ascension into heaven, and now last Sunday, the coming of the Holy Spirit to give us the courage and to give especially his apostles and his followers the courage to bring the gospel to others. And the night before he died, Jesus asked Peter, "Do you love me?" And he asked him 3 times. And Peter got a little annoyed with him and said, "Listen, I've told you already that I love you. When are you going to realize this?" But each time he told Peter to feed his lambs, to feed his sheep. And so that's what our mission is in the world, to bring his love and God's love to all people, not whether they're his followers or not. And I think that's important, especially for us in the Catholic Church, and some of this also has been very evident in the media in the last month or so, when we believe that we've kept an unbroken line of passage of the leadership of the Catholic Church from Peter all the way down to the most recently elected and inaugurated Pope Leo the 14th. And so again, we have this feeling, just as in many of churches, that we need to continue the love. And that's what our mission is, and that's what we should be doing in our healthcare, in our human development activities, and in all activities. We also, as the Holy See, it's recognized as a sovereign country as well as a religious structure. And so we've been able to, from the very beginning of the United Nations, and even before the United Nations, with the negotiations around the League of Nations, be recognized as a country that brings its voice to other countries, but with a very different perspective. The ethics, the focus on the human person from conception to natural death, the dignity and the uniqueness of each and every person. And so we become very involved in trying to advocate at that level of the governments, but then also at all of the local levels that you've talked about. And I was going to share with you some of the statistics, but I don't need to do that. If Doug and Mona want to share what I had prepared, it'll be fine with me. But it's really at that local level that the love gets passed from one to the other, but to those most in need, and for that love to be given to every single person, no matter what their faith is, no matter if they think they have no faith, and whatever background that they come from. So thank you.
Thank you. So I'm getting the sense that checks and balances internally to ensure that there's one group working, but the other one to ensure that they're keeping to the ethics and the values, and the idea that we are working for everyone, regardless of religion, regardless of social status. These are the things that has been most impactful about the church in discharging this function we are talking about. Now, given this situation, what risks or challenges does the church face? What changes or adaptations should the church embrace today in order to strengthen its role in delivering life-changing holistic care? So we have just talked about how it does its work, but now we're getting to the issue that in today's world, in today's changing world, there are obviously new things that bring about challenges for the church to continue in this role that you have just ably articulated. What is your response to that?
Well, I think one challenge is that we keep faithful to the gospel and not try to embrace change for the sake of change. And there's a lot of pressure in the world today to do that, and there's a great risk that we face by growing secularism, people who claim they have no faith and don't want the faith communities to have a faith either. But we know from our experience throughout the world that the greatest majority of people do have faith, and that they trust us because we are showing that faith in an unbiased and an impartial way. So I think we need to stay with our basic values. At the same time, we need to make sure, especially, that our health care and our health advocacy is based on good science. And we have a calling to be able to make sure that that happens. And so one example that we had in the Catholic Church was that when the COVID-19 pandemic was defined as a global health emergency, Pope Francis at that time convened a special working group on COVID-19, and we had several different working sector groups under that because he wanted not only for us to look at the medical and the scientific aspects, but also the social, the political, the economic aspects. And I was privileged to serve as a co-chair of the Health Task Force and also on the Economy Task Force. And he also wanted to make sure that he showed people that they needed to be vaccinated for their own selves, but also for everybody else around them. And so he very quickly obtained the vaccines that we needed to vaccinate the people who were working in the Vatican, but also he made sure that the vaccines were shared with the poor people who gather near the Vatican and also ask for help for food, for shelter, and for social services. So he brought in the poor people into the same area that the Vatican officials were being vaccinated so that we could show that we were reaching out to all people and have them trust. I think the other thing is that we make sure that even within the science, we make sure that we focus on the human person and on the dignity of the human person all the time, because some people think there's a great gap between science and faith, and there isn't. It was many religious people who made the greatest scientific developments, but we have to make sure that we don't compromise our ethics and our focus on the person for people who may be misinterpreting the science as well.
Thank you. Dr. John, Priya?
I think in terms of change for the church, it's important that the church understands that they too come under a law. They too need to follow the law of the land. So getting their papers in order, getting their systems in order is very, very important, because that's the challenge we are finding in our country presently, where the government is finding fault just because systems are not followed. And that cannot be the witness of the church. They have to change over there. Now, we talked during the devotion, the praise and worship, we talked about, there was a line about setting the church on fire. And in today's world, we're talking about the light and the salt, being the light and the salt, but we're also, I'm reminded of a secular song which is called I Leave the Light On. And it's about a friend singing to another friend who's struggling with a drug addiction problem and who's ready to take his life. And this friend says, I will leave the light on for you. Now the church needs to leave that light on. It's not just at the pulpit on a Sunday morning you have a fiery speech, but it's leaving the light on for anybody and everybody, like Monsignor said, to come to a place of hope, to a place of forgiveness, to a place of holistic healing. And if that we can do, that is the change we need as a church, to stand as a witness for good ethical practices, to be the guiding light for anyone and everyone who needs it. Thank you.
I promised you that we are going to have fireworks, didn't I? You can sense the wisdom grounded in praxis, isn't it? So my last question, and after that we will have the audience ask their questions, is what advice would you give to church leaders? 1. 2, church-affiliated institutions like the ones we have here, and the believers, the congregants, in terms of being the salt and light in the health sector. I think today, from devotion in the morning to the presentation which was given, this theme has kept coming back, the idea that you are the salt and light of the world. And we had a presentation which was talking about how we can regain our saltiness. So I ask you, if you had a congregation of all the church leaders and all the FBOs, we call them FBOs, faith-based organizations, and the believers, what message would you have for them with regards to our discussion, being the salt and light of the world, the prophetic voice in the health sector, but also the technical arm of the church in the health sector? I will start with Monsignor Vitillo.
In terms of the church leaders, I would appeal to them to use their voices, because they have power also with the state that they don't always realize, or they may be fearful that they're going to offend a state leader. And I think they need to bring the lived experience of the people in need up to that level. I noticed when I was working, and I wasn't representing the Holy See in all of the United Nations. I was really following the WHO for 19 years on behalf of the Holy See. But I noticed that many, many times we would invite people from the grassroots to come and speak at the United Nations. And even their own diplomats from that country didn't know what was going on with the real people in the country. The church leaders do, and they need to speak it out. And I'll give an example of that. During the pandemic of HIV and AIDS, I was privileged to be very, very active with Catholic organizations, but with many others. Many of your organizations were in some of the work that we did together. And I was asked by UNAIDS once to go to a southern African country which had one of the two countries that had the highest rate of TB and HIV there. But the government wasn't paying attention. And so we were asked to come and to meet with the religious leaders and fire them up for them to go to the government. And we were able to do that. And then also at that time I was with Caritas Internationalis, and we worked together with World Vision to do a Sunday homily instructions for every Sunday of the year. We have many shared lectionaries in our churches now. And so we were able to do short messages about HIV so that then the priests at the local level or the ministers could bring that message to the people to change their behavior as well. So I think that's the kind of work that we could do to keep the salt and the light shining brightly and tasting very well, because in the gospel, Jesus said, if the salt loses its taste, it has to be thrown away and trampled on. So we need to make sure that we have that salt nice and tangy all the time. And we can do it with our values and with our force of loving people from the top of the world all the way down to the grassroots communities.
Thank you. Dr. John Priya.
Yeah, thank you. And just to follow up from what Monsignor said, yes, in our mission hospitals, if I were to ask you how many of the what percentage of hospitals have chaplains present in the hospital, what would be your number, your guess? Out of the 275 hospitals, how many do you think have chaplains? All? No. So sadly, we have almost less than 40% of them who have a chaplain. So our appeal as CMAI, as health workers, is that the church adopts a hospital in their region. And it doesn't have to be of the same affiliation. You know, you can just adopt a hospital and say, yes, we will come here just to pray for your patients, or just to bring in that aspect of holistic healing. Because it's easy for us to do our job as healthcare professionals, but we need that extra time, that extra effort, which can only come from a chaplain as a counselor. So that would be a big appeal, and which we are working on in a few ways. And the other thing is, as church leaders, especially at the bishop's level, we need your permission to start training the pastors at the congregation level. Without their permission, the pastors don't come. The pastors don't get the funds to come for training. And we need that permission, because those pastors will make a difference at the congregation level and for the community they serve, because the community sees the light in that church. And that's where the change will happen. So that's the appeal for the churches. Yeah.
I noticed that both of you had something to say about the leaders. But I want to hear something about the church-affiliated institutions. So I will get back to you. The church-affiliated institutions.
Well, first of all, I hope the church-affiliated institutions are seeing the role that they play also with regard to handing on faith. And I think it's really important not only to have the chaplains in the health institutions, but also to get involved in helping to train the doctors to be sensitive to the spiritual issues as well. And I've been grateful to be involved with George Washington University here in Washington that has an Institute for Spirituality and Health, and together we've been able to develop, first of all, an international definition of spirituality and health. And then they've been, in many different countries of the world, pairing doctors and chaplains to do a spiritual inventory of the person, if they say that they have faith, and if they want to explore a little bit the spiritual needs that they have related to their health problems or related to other problems in their lives. So I think the health organizations need to be conscious of that, we take a holistic approach to the body, the mind, and the spirit of people, and not only identify one particular part of the body that I'm going to fix, because that's a real problem in medical care these days, but also that they're going to recognize the spiritual part of them as well.
Thank you. And your last word on this?
Church-affiliated institutions. I think one of the important ones that we have here with us, EFICOR, which is the Evangelical Fellowship of India Commission on Relief. So like that, there are others dealing with bioethics, dealing with health itself, and also with law, with the rules and the regulations of the country, and state-wise. So those institutions is where we need to partner with, and that's what we do as a Christian Health Association. We bring together all these partners under one roof, and we bring in the church at the regional level. So those little platforms and forums make a difference, because everyone is there. The lawyers are there, the healthcare workers, the church-affiliated institutions. Everyone is there to give us that understanding of how do we make it work for the community in the best way possible.
Thank you very much. And now, ladies and gentlemen, as promised, this is now your time. Can we have people who have been taking the microphones? Oh, we have volunteers. Thank you very much. We're going to take 3 questions at a time. We're starting with the lady there. Is there any hand here? This side? Okay. Yes, please.
Okay. My name is Nkatha Njero from the Africa Christian Health Association's platform. For many of us, faith-based health systems and organizations, we have found ourselves in a place where, for a long time, we probably forgot our missions and worked with whoever put money on the table. Mm-hmm. But a time has come when we've had to go back to the drawing board and rethink our missions. My question goes to Monsignor Vitillo to ask you for advice. As we go back to the drawing board and engage with the church and think about the missions of our own organizations that are founded by the church, what advice do you have for us in engaging with the church? What is going to work in terms of helping us to work together as the health systems of the church and the church leadership in trying to make sure that we get back to doing what we were founded to do?
Thank you. Yes, ma'am?
I'm Mariam Suba from Liberia. My question is also related back to what we were talking about this morning, looking at the voice of the church in a domestic setting. Like we are concerned with the funding removed from USAID, and now we are back in our countries. I mean, what would be some inputs from the two of you in terms of how we get that domestic thing working? What needs to happen with church leaders? Sometimes, for me, it's like very important that we realize that there can be no health without peace. And you find that the countries are really in turmoil. We have all sorts of different conflicts. And trying to get the church to focus onto both peace and health, as well as how can we get that domestic funding and cooperation from the political leaders. What can the church do in that light? Thank you.
Thank you. The last hand for this round. If there's none, we can, as people are thinking. So the first question was related to mission drift. And I think the session, the pre-conference session, which was dealing with leadership issues, raised important things which I think it will be important for the rest of the conference to hear. So we'll start with you, Dr. Priya. What do we do for institutions who, because of chasing requests for proposals and applications and opportunities, you started out chasing the North Pole, and after 50 years, you suddenly find yourself unintended in the South Pole. How do you get back to your original mission and vision?
Thank you, Nakata, also for the question. I know it was for Monsieur, but I'm going to just take a little stab at it. One thing that we have started doing for Mission Drift is going back to our constitution. I'm sure you have a constitution where you have articulated the objectives of why your institution or organization was even started. So we need to go back to those objectives. What is that primary object that is written? And then start looking at ways, at activities that will contribute only to those phrases in your objectives. Otherwise, we get lost with the objectives of the donor. And we lose who we are. We were set up 120, 30 years, whatever your organization's age is, ago for a specific reason. What is that reason? Go back to the objectives and then start making your activities and your priorities to ensure that this is what we will achieve as an organization and this is what we stand for as an organization. Thank you.
Monsignor, mission drift and the church?
Well, first of all, I think we all know the disaster of the cutbacks in funding, not only by the U.S., but also by a number of other governments and other organizations. I'm kept awake at night and have nightmares about the lack of the care that will happen at community level, and also the lack of the medicines, and especially the new infections, the HIV, TB, malaria that we're expecting as a result of it. On the other hand, though, I think it's going to force us to look more about our original mission and also force us to be more creative and learn how to work together. And I'll give an example of that. Since 2016, the Vatican was convening groups of pharmaceutical manufacturers, diagnostic manufacturers, faith-based organizations, and some of your organizations have been involved in this, and regulatory agencies on the fact that at that point in time, we did not have the right formulations and dosages and diagnostic tools for children living with HIV and for TB, and they weren't benefiting from the progress that was made in the adult populations so affected. And we were able to get the pharmaceutical companies both R&D and generic to work together, and also to open up some of the regulatory problems that were blocking this, and then, of course, working with the faith-based organizations to do the rollout. And we have quite a kind of combination now, but there's more that needs to be done for the future. We had planned a meeting on the 3rd and 4th of February this year to continue that process. And then we really struggled for the week before that because all of these revelations about the US funding came out, and I began to think maybe we should just cancel the meeting, but we didn't. And as we came together, we had a much more creative discussion at that meeting, even though we were hurting around the foot cuts, because they said we have to go back to who we are. And even the pharmaceutical companies were looking to us for some of the answers for this now, because they were worried about their market, but also they were grateful that they were involved in this process of helping to save children's lives. And so I think that's one of the things we have to do, is keep faithful to our mission and also then influence other people. The other thing is, I think, is around partnerships, and some of that was mentioned before. We can't do it alone. Not one country, not one faith community, not one government can we do it alone. And so we need to really look at our partnerships again. And I have to say I'm very impressed by some of the progress that's been made, especially with African governments, and also Bruce Compton from the Catholic Health Association of the USA is here and has played a big role in this in terms of preparing ethical guidelines for partnerships and changing the structure, because too many times partnerships were defined by the donor and not by both sides. And I think the ethical guidelines that they've developed have been very helpful and will provide us with a real framework for the new way of doing our service to others.
We're sharing a mic now. Yes, partnership. So the last call for questions, comments, violent protests. Okay, we'll start there.
Thank you very much for this discussion. Sam Omenda is my name, from Kenya, working with the Faith-Based Health Network. I feel that what we are discussing probably should not be about change. It's about reclaiming our original mission and purpose and how we are structured. But I think the context has all changed over the years. In the past, our faith-based institutions used to have partnerships with church and church, sister churches abroad. So there was a connection. And we used to benefit from maybe support, technical support, expatriates that would come and help us in areas, but also flow of supplies, sometimes resources. Over time, that declined. And at the same time, cost of health systems has been increasing. The regulatory space is becoming more and more difficult. The disease patterns have also changed. We're dealing with a lot of communicable conditions that you could deal with easily. Now we have a double burden of non-communicable disease, very expensive to diagnose, treat, and so on. So the reality is that as we reflect about going back, reclaiming, and working on sustaining these services, we have to work around partnering with governments more in terms of getting support locally within our own countries. I know our own governments are struggling, even meeting the support for their own health infrastructure and health institutions. But then the other funding arrangements, whether social health insurance, community health insurance, national health insurance arrangements. But then for us to be able to work in that space, we have to comply with the requirements. in terms of to get empaneled, to provide the services, to be able to get paid and so on. So there is still capacity and system strengthening that is needed. And we have to think about how do we help the poor, particularly and vulnerable. That was always, the core mandate of the churches in doing this mission work. So my appeal would also be, can we also strengthen our relations as church and church institutions across the world, so that we help each other, even as those other sources of support may be changing or declining or becoming more difficult to access. Thank you.
Sounds like the reflections of someone who back home people expect answers to all these questions from. So when they look at people like Dr. Mwenda, they look at Dr. Priya John, Dr. Tumwesije, and so on, there's an entire segment of the population, significant millions, wanting these people to have answers to the issues he has raised. So we'll take that as a submission. If you want to comment on it, you are free to comment. You want to comment immediately?
Well, as Sam was in, Sam's a good friend for a long time. I'm happy to see you here, Sam. But as you were talking, I was thinking of another area, and that's on pastoral care, where we had many missionaries coming to the South to bring the faith to people, and then the churches, the local churches grew up. Now we have the opposite, at least in the Catholic Church. We have many people, priests and sisters coming from the South to the North, because in the North we're dying. There are no new babies being made, and also we need vocations to ministry. And so I think just as the southern populations have been able to provide pastor care, I think it's a challenge also to them to see what kind of resources they could deeply into as well. And in many countries, there are a rich group of people who don't always donate to care for those who are most in need in their own countries. So I think that's a challenge for one thing. And then also, again, as we redefine partnership, then it has to be a dialogue. It has to be talking with each other. We have to find those solutions together. And then we also need to talk to the governments to see how they're allocating their money. Because in the North and in the South, there's so many expenses going to military, to wars. And that was a constant voice of Pope Francis about that. And now, once again, of our new Pope, Pope Leo XIV. Let's see how we're spending our money, and we'll have a lot more resources to do integral human development.
Thank you for reminding us that the needs are infinite, but the resources are finite, and we may have to also pay attention, not just to throwing more money at the problem, but also at looking at how we can do more with less. The last three hands, very quickly, yes?
So, my question has to do with primarily hospital sustainability. So the West, high-income countries have pretty much done away with religious hospitals. Now, that's not to say they're all gone. There are still Catholic hospitals and Adventist hospitals, but for the most part, the West has abandoned hospital management. It's too complex, it's too costly, and it seems like that's beginning to happen. In India, I hear that there's closures because of competition. The government is building hospitals. So do you have hope that low and middle income countries can maintain their management and hold on hospital facilities, or are they going to go the way of the West?
Thank you.
And if you think there's still hope, why? Or how could that happen?
So hospital sustainability in the face of funding landscape changes. There was, yes?
You don't have to be a pastor to lay hands and pray for somebody. 1990, my partner, who was Hindu, brother-in-law, was dying of brain cancer. And every couple of months, I'd hear the unfolding story, and every time I would hear from the Holy Spirit, have an anointing for Robbie. How do you have an anointing for a non-Christian? So I duffed it. But after about a year and a half, I got a phone call, asked to switch call. I asked what was going on. They said they were flying Robbie back to the home country to see the faith healers. So then I called my pastor up and said, would he be willing to have an anointing for a non-Christian? And I knew there was biblical precedents for Naaman the Syrian being healed by Elisha and Christ healing the Syrophoenician woman. He agreed. So we met in the chapel, my partner, his wife, 2 children, and 2 grandparents, myself and the pastor and Robbie, and then I called a friend for prayers, and they showed up. So we had about 10 people, 12 people putting hands on Robbie and praying. And the Holy Spirit was clearly present there. It was palpable. The next day, Robbie flew back to India and died a month later. And so you're wondering, why am I telling this story? Because about 6 weeks later, Robbie's sister, which is my partner's wife, I bumped into her. I'm sure God orchestrated, because I never see her in town, but I did that particular occasion. And she came up, put her arms around me, crying and thanking me for the anointing. And I said, why? I was crying. Why? Robbie wasn't healed. And she said, you don't understand. There was division. And I suspect it was between Vanita and Rakesh. She said, there's division. You healed the family. And what I'm getting at is that we need to be obedient to the Spirit. I just had dinner with a lady a week ago, and I felt led by the Spirit to lay hands on a friend of her who's also dying of a brain tumor 4 months ago, and she died from a brain tumor. But this friend of the lady that died told me that laying on of hands on her was so meaningful. So sometimes laying on hands does not bring healing. I have been involved in a few miraculous healings, but we're called to be obedient to the Spirit. I'm a layperson. I'm not a pastor. And you've got a huge army of laity that we need to encourage. And how do you spark the spark? We listen to the Spirit. We look for the Spirit. And the Spirit has a sense of boldness, and the Spirit speaks to you. The Spirit will talk to you and tell you what you need to do. And like myself, if this was over a year and a half, I'd say probably half dozen or more times the Spirit said, have an anointing for Robbie. And you can say I'm crazy, but you look at the outcome. Thank you.
Thank you for that powerful sharing. The last hand. Okay, you give it up. So hospital sustainability question, I guess, is our last stop. How do we, in the context of national health insurance, community health insurance, standards, and so on, how do we continue with the competition from government and so on? Your last word on this, and as you're addressing that, what are your concluding remarks on this panel? Your last thoughts.
Thank you for that question. I think it's a very important question. I think every country is asking themselves that question. In 1998, there was a study done by the World Council of Churches, and CMI too was part of that study. And they looked at sustainable hospitals versus at-risk hospitals, is how they put it. And they looked at factors that contributed to the success or the failure of the hospital. And one thing that stood out was the presence of one important specialty or one important service that that hospital provides, and which the community recognizes as an important service for them. When hospitals had that, that one service which really stood out, that hospital was more likely to be successful. The other thing is when, why do people come to mission hospitals? Do you know what the word is? What is the reason they come? It's not compassion, it's not love of Christ, it's trust. When we are clear about our ethical values and we provide service that is trustworthy through generations, because that's why they come to the mission hospital. Because my great-grandfather came here, I am coming here. And that trust is another very important contributing factor. But you're right, the maternal and child health services, which was the bread and butter, contributing to almost 70% of the revenue of any of our mission hospitals, is now slowly taken away by the government. What do you do then? If that was your special service, your special service to the community, what now? Yes, there are still areas where we need to bring in the mission of Christ. He's saying, look at the poor, look at the vulnerable, look at the marginalized. Maybe mental health, palliative care, geriatric care. So many areas where the government is saying, yeah, it's okay, you can take that bit, we'll do the rest. So let's take that bit. Yes, it's not big income generating services, but it will be the mandate of the mission of Christ. And that's what's important at the end of the day. And God will bring the sustainability just like that. Thank you.
I like those last words. Over to you.
Well, one thing is I don't accept that the West has given up on faith. I think that there will be a resurgence. Okay. Okay, sorry. Okay, no, thank you then. But I do think that there's a resurgence of faith in the West as well. And I have great hope that the faith will be preserved in other countries as well. But in any event, I think that just as Dr. Priya said, I think we have to keep on hope. And we may not have all the answers on how we're going to be able to sustain the healthcare structures in all the places in the world, and especially those that are experiencing these cutbacks of funding. But I think together we could find those. And I think we have to be patient. We have to have real dialogue. In the Catholic Church, I think we've learned that, especially through Pope Francis's leadership, that we need to expand the dialogue. We had 2,000 years of the bishops coming together for synods alone and teaching. And I believe in the teaching mission of the bishops and the authority of the bishops. But Pope Francis said we need to expand those discussions. And we now had people, lay people, religious priests, sisters, brothers, and the bishops sitting at the same tables in our 2-year synod that we just completed. And that now Pope Francis extended shortly before his death, so it's going to go on for at least another 2 years. And there were very different conversations. And the document that they submitted, Pope Francis said, I don't need to do a new document, I just signed this one. So I think that's where we'll be learning by expanding our discussions and finding the solutions together.
Ladies and gentlemen, fellow pilgrims, the conclusion is we dialogue, and through our own reflections and collective dialogue, we'll find the solutions to answer the two questions. How does the church continue to be the prophet, the voice of prophecy in the health sector, but also the technical arm of the church to bring about compassion, healing, and holistic care to the peoples of the world? We end with a big clap for our panelists.